the spiritual state and how that affects everything else. We went over our modifiable personal lifestyle factors, which are your sleep, relaxation, exercise and movement, nutrition, stress, and relationships. Everybody can benefit with some sort of a prescription here. It would help all disease states. We talked about mediators. We talked about triggering events. We talked about some antecedents, but now we'll talk about the major antecedents, which are your genes. So that's where we're going to focus this morning. And I will try my best to make this fun for you and easy to understand. I know the topic can sometimes be a little bit heavy. And what I would say is just write down, take your notes, realize that you might not get it like the first time around, or you won't get everything the first time around. What I recommend is just be ready to read the notes again, listen to this again. And I'm hoping at least if by the end of this, you understand the genetic piece just a little bit more, I've done my job. So quick question, if you can put in the chat box, do you check specific genetic variances? Are you checking APOE? Are you checking for familial hypercholesterolemia? Are you checking MTHFR or that type of thing? If you do, go ahead and put in the chat box that you do check these currently in your office. And then if your answer is yes, if you do check them in your office, if you could just jot down what lab are you using and what do you like and dislike about it? Awesome. Our approach. When it comes to genetics and SNPs and what's out there, there is an overwhelming amount of things. There are overwhelming amount of genes to look at. The reality is that you can't look at everything. It's overwhelming, and we don't even know what to do with half of them, actually more than half of them. So what we're going to want to look for are genes that are relevant, that are prevalent, that are measurable and modifiable. If you can't do nothing about them, I'm not sure I'd want to know. And we are, in particular, we are looking at the cardiovascular system. So this isn't a full genetics talk. In regards to the cardiovascular system, we could very easily do a whole workshop. We could do a couple of modules on this, but we picked what we feel like are the most important SNPs for everybody to know, or genetic variances for everybody to know. So we already covered in this course ApoE and what to do with ApoE4, and we also talked about Lp(a). Now, Lp(a), when we're checking those levels, Lp(a) is driven by genetics. However, it's not something we readily look at the genes. We look at the levels, but we know that that's driven by genetics. So Mimi has already talked about the Lp(a). I've already talked about ApoE. So moving forward, here are the genes that we're going to discuss. Familial hyperlipidemia, or here are the genetic variances that we're going to look at. Genes involved in familial hyperlipidemia, MTHFR, methionine synthase, and COMT. And at the end of the deck, we have bonus slides for you. We put some more information that really, we didn't have enough time to go over all of it, but something you can look at your leisure, and also a little cheat sheets on what we talked about for today's lecture. So let's talk about the first one, familial hypercholesterolemia. And luckily, I know you're going to love it. We got a pop quiz. So if you're not ready for it, get ready. You got like 2 seconds. Our first question, what is the risk of premature coronary heart disease among the familial hypercholesterolemia patients? So if somebody has familial hypercholesterolemia, what is the risk of premature coronary heart disease? A, 3 times more likely. B, 4 to 5 times more likely. C, 6 to 10 times more likely. And D, greater than 10 times more likely. Go ahead, put in the chat box below your answer. The only wrong answer is leaving it blank. Just put a letter if you can't even think. Just put it in there. Judge-free zone. The answer is D, 20 times more likely. The prevalence of familial hypercholesterolemia in the US is about 1 person per blank people. A, 25, B, 50 to 299, C, 300 to 500, and D, 501 to 1,000. What is your answer? Quickly put it in the chat box. A, B, C, or D? The prevalence of familial hypercholesterolemia in the US, 1 per how many people? The answer is C, 1 per 250 people, which means that it is very likely that we're going to see multiple patients with familial hypercholesterolemia. So let's talk about familial hypercholesterolemia a little bit more. It is the most common autosomal dominant genetic disease. It manifests as extremely elevated LDL. So that LDL is sky high. If you're heterozygous, remember heterozygous means one faulty gene. You can get premature cardiovascular disease at age 30 to 40. It's the most common form. That's 1 per about 250 people. So luckily, this is the most common form that we're going to see. Homozygous, remember, 2 bad genes, 1 from mom, 1 from dad. You end up getting severe cardiovascular disease in childhood even. So homozygotes are rare, luckily. It's 1 per 300,000 to 1 per 400,000 people. So luckily, we won't see many of them, but if we do see them and we do catch them, we're going to want to jump on that real quick. Patients often develop cholesterol deposits under the skin, tendons, and cornea. So you get these cholesterol deposits you see on physical exam. If it's untreated, you have a 20-time increased risk of coronary heart disease. 50% of untreated men will have an MI by age 50, 30% of untreated women will have an MI by age 60, and 20% of all MIs before 45 are due to familial hypercholesterolemia. And guys, we are seeing it. Guys and gals, I'm sure you're seeing it in your practice. People younger and younger are getting heart attacks. Now, these abnormal cholesterol deposits, they're named different things for the different areas that they're at. So tendon xanthomas, that's when the deposits are in the Achilles tendon and the dorsum of the hands. The plantar xanthomas are on the palms of the hands and the soles. They can be painful. The xanthelasma is on the eyelid, like this picture here. And corneal arcus is around the cornea. So you see that white kind of haze around the cornea in this picture. That's a corneal arcus. So this person has 2 in one picture. Go ahead and look up the tendon xanthoma and plantar xanthoma. If it's something that you wouldn't be able to kind of pick up that you're not familiar with, go ahead and Google that so that or check the search engine of your choice and take a look at that picture. Approximately 95% of patients that have familial hypercholesterolemia are going to have a mutation in one of these things. They're going to either have a mutation of the LDL receptor, of APOB, or of PCSK9. That's the majority of patients. So let's talk about LDL receptor. So if you look at the LDL receptors here, remember what the LDL receptors do. The LDL receptors are going to grab LDL and pull it into the liver and then break that up, break the LDL up. And then what's going to happen is the LDL receptor is going to go right back up top to the top of the liver, and it's going to be recycled and it's going to pull another cholesterol out. Now, if those receptors don't work properly, then what's going to happen is they're not going to be able to pull cholesterol out of the bloodstream, which of course will lead to higher amounts of cholesterol. 93% of cases have the LDL receptor issues. Unfortunately, there is 1,600 variants. So 1,600 possible genetic variants of this. It is not something that we can readily start checking right now. But just know, if you see this really high cholesterol early on, it is probably this just by chances, 93%. The second most common mutation is going to be a mutation of ApoB. So remember, ApoB is on top of the LDLs and IDLs and whatnot. So this lipoprotein is responsible for binding to the LDL receptor. And when it binds to the LDL receptor, that's when the liver can take it in. So what happens is that an abnormality in ApoB will make it not stick as well to that receptor. So of course, if ApoB can't stick to the receptor, what's going to end up happening? It's not going to be able to pull the LDL into the liver, which means your bloodstream is going to end up with higher amounts of cholesterol. And that's the second cause or major cause of familial hypercholesterolemia. 5% of cases, and I left the RS number, the genetic variant or the most common genetic variant the RS730880052 if you feel like researching and looking this bad boy up. The third most common mutation associated with familial hypercholesterolemia is a mutation of PCSK9. So if you remember, PCSK9 comes and binds to the LDL, the LDL and LDL receptor complex. So take a look at that bad boy, that little green PCSK9 that's just chilling, acting like he's all innocent. But if you look further down, what happens is he or she sticks to the LDL receptor LDL complex. The liver takes it in, and he just holds on and doesn't let go, and holds on and doesn't let go. And then the receptor and the LDL get destroyed along with PCSK9. And then that ends up in less receptors. So normally that receptor can be recycled, but with an issue with PCSK9, with higher levels of PCSK9, that's not the case. And I left the most common genetic variants. This is only 2% of the cases, but it's worth knowing about, especially because we have natural and we have medical treatments for PCSK9 inhibitors. So what's the definition of familial hypercholesterolemia? There's multiple definitions based on the institutions that put the definition out, but to me, the easiest is the American Heart Association criteria. The American Heart Association criteria says that if you have an LDL greater than 190, plus a first-degree relative with an LDL greater than 90, or known premature coronary heart disease, 55 years of age in men, or less than 60 years of age in women, then you have familial hypercholesterolemia. And I want you to take a look at that, because I want you to think about how many of our patients will get an LDL of greater than 190. Many times we get their numbers far down to normal without medication, and just take note of that. But this is a legal liability. You want to realize that when it's that high, you want to at least be able to document in your chart that you are making that diagnosis, and you want to talk to them about first-degree relatives in order to kind of come up with this diagnosis. So what are the clinical implications? If you see this, what are you going to do? Well, early intervention. You want to get the LDL down as low or as soon as possible. You want to make sure that you document in your chart that you said screen all first-degree relatives. And as a matter of fact, when I see an LDL greater than 190, I make sure, regardless of whether they have family members that have high LDL or whether they have family members with premature coronary heart disease, I am going to document that I told them to screen all of their first-degree relatives. So make sure that you document that. And of course, you do it. I'm saying document it because we usually do things and we forget to document, but we want to protect ourselves. Typically, what are you going to use as a treatment? You can use statins, atorvastatin or rosuvastatin, because you're going to go for high-intensity statins. That's the recommendation. Statins plus other LDL-lowering agents, or PCSK9 inhibitors. You can throw some PCSK9 inhibitors on top of that. And then if they're not getting better, or if the number is extremely high, like the people that would be the homozygous carriers, the ones with the numbers in the 300s and 400s, those people, you're going to want to start something and then refer them to a lipidologist. Now, let's say somebody is 190 and they refuse statins. Then document they refuse statins and then do your functional medicine way, but at least cover yourself. Put in the note that, well, like, let's say they wanted to do red yeast rice, great, but just say, I recommended statins, patient understands implications and risk. Despite this, patient refuses, patient agrees to taking red yeast rice and EPA omegas and berberine and whatever you put them on, but make sure you document and cover yourself. So what are the thoughts on high-intensity statins? Here's just a couple of pearls. So they're recommending high-intensity statins, and you don't always need to go directly high-intensity. I know that's what the guidelines say, but get their numbers down to the normal numbers. Do whatever you have to. But the only two that can become high-intensity statins, or that are on the chart for high-intensity statins, are rosuvastatin and atorvastatin. So rosuvastatin is usually going to be the go-to for most patients. If the patient is very sensitive and doesn't do well with rosuvastatin or atorvastatin, then pravastatin would be the next choice. However, rosuvastatin, one of the nice things about it, it does not go through the cytochrome P450, so you don't have to worry about it interacting with a whole bunch of medication like many of the other statins. But it does need to be renally adjusted in chronic kidney disease, so make sure you're looking at that GFR, and you are, based on that, you are adjusting the dose. And if they have severe kidney disease, or if they have kidney failure, then you might want to go to atorvastatin, because it does not require renal dose adjustment. And that's one of its benefits. It does, however, go through the cytochrome P450. My favorite is definitely going to be rosuvastatin. And sometimes we go really low dose. We don't go to the high intensity dose. Sometimes we're putting, based on the patient, sometimes they're on just half of a 5 milligrams every other day. But that's where patient individualized medicine comes in. One size does not fit all. And remember, our job is never over. Okay, this is a patient that ended up needing a medication, but it's not done there. Optimize their CoQ10 levels. Remember, statins are going to lower CoQ10, so you want those levels nice and high. Optimize vitamin D levels, because if people have lower vitamin D levels, they have a higher risk of having an issue with statins. And make sure that their thyroid is balanced before you do any of this, because remember, hypothyroidism can cause your LDL levels to go up, and wait till it's regulated. And if you're hypothyroid, what can happen is you have a higher chance of having a reaction to statins. So do all of that first, and then go to the next step. But if somebody does have familial hypercholesterolemia, and it is the autosomal recessive, maybe the 190, then I'll probably have them go on CoQ10 for about a week. I'll make sure that they're on some sort of vitamin D or we're replacing. Let's say in about a week, go ahead and start this medication. So now let's take a look at some more individualized SNPs, or single nucleotide polymorphisms. Just a couple of terms to keep in mind. SNP is a single nucleotide polymorphism. Heterozygous means one allele, that they have one of the faulty, you could call it, alleles, or one of the non-common alleles. And remember, you get two alleles, one from mama and one from daddy. Homozygous means you have two of the faulty alleles, or the variances that may decrease function. Homozygous is going to be more dysfunctional than heterozygous, depending on whether it's dysfunctional or not, or an increase in function. You'll see two of the SNPs we're going to talk about are going to be decrease in function, whereas one of them, you can actually get an increase in function in some of those variances, and you'll see that in a bit. RS, that's the reference single nucleotide polymorphism. That is what researchers are going to be using in order to talk about the same gene variant. So when you PubMed search and when you start looking at your research, you can type in the RS number, and the RS number, that's something that's kind of like an agreed upon number that you give each one of these SNPs. And an example of that, the very common gene mutation, there's two common gene mutations of MTHFR that seem to be relevant. One's the A1298C, and one is the C677T. So the A1298C, when you look into the research, what you can type in is RS1801131, and that is going to help you find the research done on this variance of the MTHFR. Also keep in mind, this is a work in progress. The more you know, the more we know, the less we realize we actually do know. Remember that every variance, I catch myself when I call it faulty or dysfunctional, because every change in the genetics in the single nucleotide polymorphism can have an advantage and a disadvantage. So it may help in some things. There are many SNPs that can involve one enzyme. And what we want to look at are the ones that are the most impactful. I mean, there's over 10 I think there's even more than that, of just MTHFR variances. But we're going to stick to the ones that we believe are clinically relevant. Evidence-based, we're looking at evidence-based cardiovascular disease relevant SNPs. So what we're looking at is where these SNPs, either where we would reasonably believe from the research that these SNPs can cause or worsen cardiovascular disease, because this is the cardiovascular module. Evidence to, if you find any evidence or any SNP that you feel like it is easy to do, it is prevalent, and it's something that really should be in this lecture, it is a work in progress, please give me an email, drelliman@gmail.com, and send me your references, and I will send you a thank you very much, and I will review it. Supplements for a SNP, we don't do that. We're not going to want to just say, if you have this SNP, take this supplement. We're going to put people on the least amount of supplements possible to get the job done. And there are times where you're not going to be on a supplement for a particular SNP. An example is, I have the MTHFR gene mutation. It is very rare that I have to take methylfolate. So let's talk about methylation, since we're going to be talking about methylation SNPs. What is a methyl group? It is a carbon with 3 hydrogens. That's a methyl group. And methylation is the addition of a methyl group to a substrate. So basically, a methyl group, the CH3, goes from one substance to another substance. It's needed for metabolism of neurotransmitters, hormones, drugs, and xenobiotics. And it also is needed for repressing gene transcription. So I'd like to give you some examples of methylation reactions. So as the methyl groups are being passed, as the enzymes are working and their substances, they're giving up their CH3 to other substances, things are happening. For example, your homocysteine, which high homocysteine increases plaque, it's neurotoxic, it can increase memory issues. It needs a methyl group to get methylated to become methionine and eventually SAMI. And SAMI is a major methyl donor in the body. SAMI runs around and helps activate all kinds of things. Another one is tyrosine. So you know the amino acid tyrosine, it needs to be methylated to eventually become dopamine and norepinephrine. So just think about it. If you have low dopamine, you're going to have a decrease in motivation, and you can also get depressed. And if you have a decrease in norepinephrine, it's going to be hard for you to focus. So if you are not methylating properly, you can't take your tyrosine and make it dopamine and norepinephrine. Methylation is what does that. Tryptophan needs to be methylated to eventually become serotonin to help with sleep and relaxation, and melatonin that helps with sleep. So histamine and actually low serotonin can cause depression, as you know. That's why we have the SSRIs. So histamine, when your body releases histamine, it needs to be broken down, and it's methylated to get broken down. Otherwise, if you have a whole bunch of histamine going around, you're going to have rashes and itchiness and whatnot. So, and the list goes on and on. I just wanted to give a couple of examples to show you why methylation is important and why understanding methylation is going to be important to help care for your patients. Now, it's all about balance. You don't want to over-methylate. You don't want to under-methylate. Somewhere in between is what we're looking for. If you over-methylate, it can be associated with anxiety and depression and paranoia and nervousness, sleep problems, and the most horrible symptom of all, low libido. Under-methylation, and the low libido, I just got to say, like, this is research-based. I asked 2 of the guys that work in our office what's the worst symptom on this list, and both of them said low libido. So to me, it's kind of like a 100% there. You can't really contest that. Undermethylation can lead to fatigue, depression, OCD, headaches, histamine overload. And think about the symptom of histamine overload. You can get migraines, you can get itchiness and whatnot. And a high libido, not necessarily a bad thing. I have to pull the same 2 guys when we're all in the same room at the same time with the door locked. So let's take a look at production of 5-methyl tetrahydrofolate, because this is where I think it usually starts for a lot of us when we get into these SNPs and genetics. It's the MTHFR gene. So let's take a look at that gene that makes the MTHFR enzyme. So the MTHFR gene encodes the MTHFR enzyme, and the MTHFR enzyme is the last step in folate metabolism. Methylfolate is a major methyl donor, so it runs around and it can give its CH3 or its methyl group to other substances to help activate them or whatever, deactivate or whatever it has to do with them. Data shows that if you have the MTHFR gene mutation or specific MTHFR gene mutations, it can increase your risk of hypertension and cardiovascular disease, mainly though in conjunction with hyperhomocystinemia, because if your MTHFR isn't working, that can cause your homocysteine levels to go up. So let's take a look at this pathway. So first of all, let's talk about the folate metabolism pathway or folic acid. So folic acid is found in fortified foods, and it's synthetic. It's kind of made in a lab and thrown in foods and put in supplements. It is not the same as dietary folate. So don't let people fool you and say it's the same as dietary folate. We don't have time to get too far into it, but you want to get your folate from dietary sources that are naturally occurring. But that folic acid can be converted to dihydrofolate, and dihydrofolate can become tetrahydrofolate. And tetrahydrofolate, with the help of B6, can become 5,10 methylene tetrahydrofolate. And then through the MTHFR gene, which is we're going to talk about the variants in this gene, using a cofactor of riboflavin, you get 5-methyl tetrahydrofolate. So let's stop there. In order for folate to turn into this active form, this 5-methyl tetrahydrofolate, or we just call it methylfolate for short, you're going to need a working MTHFR gene, you're going to need folate, some sort of folate, and you're going to need B6, and you're going to need riboflavin. So just think about that when you're dealing with disorders of the MTHFR gene or people with high homocysteine. The clinically relevant SNPs, there are multiple MTHFR SNPs, but like I mentioned, there's 2 clinically relevant ones, the MTHFR A1298C and the MTHFR C677T. I left the RS number here. If you're heterozygous, you're probably working in the 70%. Heterozygous means one of the abnormal genes or one of the lower functioning genes. And if you're homozygous, both of them is a little over 50%. So it's working at about 50% of what it should. Now you could have a compound heterozygous, and that's where you are heterozygous for the A1298C and you're heterozygous for the C677T. And because of that, it acts like it's a homozygous. So the other SNPs, not really that sure. I would focus on these 2. So when you're treating your patients, you can get 23andMe or one of these ancestry tests, and you can actually put those through you get the raw data, put them through a program, and they can show you these SNPs. Just stick for MTHFR SNP to these 2. And there's also different labs out there that are going to that can actually just do that panel for you, and you don't have to put it through another program or anything. So what are the MTHFR SNP considerations? So if you have these variants that do not work as efficiently, what do you want to do? Well, first, you're going to want to look at your homocysteine. And most functional medicine providers are shooting for a goal of about 7. I would say 5 to 7, maybe 8 is pushing it. That's where you're going to want to be. And that's how you're going to tell if you are being able to bypass that MTHFR gene or not. And there may be other factors causing the high homocysteine. You're going to want to talk about increasing the foods that are naturally high in folate, like green leafy vegetables, legumes, seeds, uncooked plant-based foods. So take a look at the chart on the right and look at how, remember, there's folic acid and then there's dietary folate. You're definitely going to want to try to get dietary folate. And if you supplement, you're not going to want to do folic acid. You're going to want to go to the bottom and you're going to want to give methylfolate. Consider, so if you know that gene isn't working well, so if you have the C677T or 1298C and you have a homozygous, so 2 faulty or 2 decreased or suppressed genes, or heterozygous of each one, your homocysteine's a little high, look at where B6 and B2 or riboflavin work. You're going to consider supplementing them. And you know what you can do? Because B6 and B2 can be methylated as well, and your body has to methylate them, you can give the methylated form. So B6 is methylated to P5P, and riboflavin is methylated to riboflavin 5-phosphate. So just think of it. So just remember this pathway when you have that your next MTHFR patient, and that's going to kind of help you with what to do next. And then what you're going to also consider is, since it's harder for you to make methylfolate, or for this patient to make methylfolate, or the 5-methyl tetrahydrofolate, what you can do is consider bypassing it by giving them methylfolate. So you're completely bypassing the enzyme and giving the body some folate, so till the enzyme can start working on its own and doing what it has to do. Now, here is where it gets fun. So you need methylfolate in order to activate this dihydropterin from BH2 to BH3. So take a look at that. You need methylfolate to make this BH4. So take a look at the BH4 and take a look at this pathway. BH4 needs to give a methyl group to turn your tryptophan to 5-HTP. And then the 5-HTP ends up being able to cross the blood-brain barrier and become serotonin. And remember what happens if you're low in serotonin. You get depression and you get anxiety. So if you have a patient with depression and anxiety and they have the MTHFR gene mutation, methylfolate may help them here because it'll help them make the serotonin. Now, what you can do from tryptophan, you want to make sure that they're getting enough protein, and because protein is going to help you boost, protein is broken down to the amino acids, and one of the amino acids is tryptophan. You also may want to temporarily, depending on how they're doing, supplement with 5-HTP because it's already methylated, and save some of that methylfolate for other reactions that have to take place. So you maybe want to give 5-HTP here to start building the serotonin. And remember something, when your serotonin is low, your substance P goes up in the CSF. And high substance P is associated with fibromyalgia. It's associated with a lower pain threshold. So small insults will turn into lots of pain. So you have those people that are feeling pain all over, that are depressed, that are anxious. You may want to start giving some 5-HTP and boosting the serotonin. And definitely work on exercise and all those other things. And then if you look, serotonin needs to be converted to melatonin with SAMI. So if you look all the way to the right, you do need methylfolate in order to make SAMI. So we'll talk about that in a second, but you can sometimes give SAMI. And then for those patients, because they're backed up, you may want to give them melatonin to help them sleep to get started. And then what you do is, when they're feeling better, you can start backing off on some of these supplements. So that now take a look at this. You need the BH4 in order to make L-DOPA, and L-DOPA becomes dopamine. So that's another reason, or that's now they have decrease in motivation and they have depression. That could cause that. And what you can do is you can give people tyrosine, and you can also give people methylfolate to help turn that into what it needs to turn it into. Interestingly, take a look at this. What about your endothelium? What about the lining of your arteries? Well, arginine is needed, and BH4 is a cofactor in eNOS, endothelial nitric oxide synthase. And what the byproduct of that is citrulline and nitric oxide. Remember what nitric oxide does. It helps open up the blood vessels. Lower nitric oxide causes endothelial dysfunction, hypertension, and vessel disease. So methylfolate may potentially help decrease hypertension, but decrease atherosclerosis. And then for the homocysteine pathway, it's kind of going a little bit off topic. The methylfolate is needed as a cofactor, but we're going to talk about that in a second. So let's talk about methionine synthase, which is the next enzyme to look at. There are two enzymes needed for the function of methionine synthase. You have the methionine synthase enzyme itself. Unfortunately, the research is weak. We do not have good data on which SNPs are abnormal, which genetic variances are normal with methionine synthase, but we do have some data on the other enzyme, the enzyme that is needed for the methionine synthase enzyme to work. And what is its job? What is the job of methionine synthase reductase? It takes your cobalamin or your B12 and it turns it into methylcobalamin. The methylcobalamin gives its methyl group to MTR. MTR can work, and when methionine synthase works, then it can start doing its thing, methylating. So what is its thing? What's it going to do? You need methionine synthase in order to recycle homocysteine. So that high homocysteine that is elevated, that can cause neurotoxicity and cardiotoxicity and memory problems, that homocysteine can become recycled to SAMI, S-adenosyl methionine. And SAMI is, like I said, it's a major methyl donor and used for multiple processes in the body. Now, what blocks this enzyme? Alcohol blocks this enzyme. So you have people that are drinking a small amount for health reasons. They don't feel like they're doing anything wrong, but that small amount is enough to block that enzyme. And one of the clues the methionine synthase is not working is if you see an elevated mean corpuscular volume. You see an elevated MCV, that means the red blood cell is large. What do you got to do? You got to check two things. I mean, what we learned in med school and the basic sciences, you're going to check your folic acid, you're going to check your B12, and those are normal. Okay, so you check those and they're normal, and you can't find another reason. You're going to think these people most probably have a methionine synthase issue or dysfunction. Methionine synthase is also the only enzyme in the brain that can convert homocysteine to methionine too. So research from a cardiovascular standpoint is lacking. We just need more time and more studies. However, just from a logical point of view and it makes sense to see how the enzyme works and try to help it out. And definitely makes sense from a point of lowering homocysteine levels because we know that's toxic. Let me tell you about homocysteine. So if you look at conventional literature, they say you should hardly check homocysteine at all, even though they know it's a risk factor for strokes and heart attacks and all that stuff. They say you should probably not check it at all because they've done research where they gave the synthetic folic acid to people that had high homocysteine and it dropped the levels, but they couldn't show that it decreased the risk of strokes and heart attacks. The problem is they were giving synthetic folic acid. The reason I'm telling you, synthetic folic acid is different than giving methylfolate or giving the activated folate. And what I would love to see is a study using the activated folate and using this functional medicine approach. We just got to wait for the study to come out. But if you look at folic acid, it's oxidized, it binds to these folate binding receptors really tight folate binding globulin really tight, and it doesn't let go. So if you start looking up the difference between folic acid and just the folate found in nature, you'll find that it's not the same thing. But anyway, the reason I'm telling you this is that when you're challenged by some of the conventional providers and and it takes you by surprise, then they think they've won and they didn't win. They are joining us because functional medicine is the real conventional medicine. So that being said, you want to be able to say, yeah, I'm aware that right now the guidelines say don't treat it. However, I have a patient with this high level. I know it's toxic, and I know the research was looking at folic acid. So we're going to use diet, we're going to use methylfolate, and we're going to get that homocysteine down in the most logical, the most natural way possible. So just be ready for that as ammunition. So let's go back to our talk here. So remember I mentioned this methionine synthase reductase enzyme. What this does is it takes cobalamin and it turns cobalamin into methylcobalamin or methyl B12. And then methyl B12 is used with methionine synthase so that methionine synthase can change homocysteine to methionine. So take a look at this. You got your homocysteine. Homocysteine can go down in the CBS pathway. Now, there's different SNPs on CBS, but the literature's still not clear on which one's good or actionable or whatnot. But just realize B6 is a cofactor. So you need B6 to drop homocysteine down. And you also need B12. If you look to the left, the cobalamin becomes methylcobalamin in order to change the homocysteine to methionine. Now, look at the zinc piece. So zinc is a carrier of homocysteine. So homocysteine travels bound to zinc, and it goes to the methionine synthase enzyme. So if your zinc level is low, then you're not going to be able to carry homocysteine where it needs to go in order to turn it into methionine. So you can already just say, all right, let me make sure that my patient has an optimized zinc level. Then the methionine synthase enzyme is going to take that methyl B12 and it's going to take methylfolate. And this is where the methylfolate comes in from the MTHFR. And together, what they're going to do is they're going to help convert homocysteine to methionine. And then the body's going to take methionine and it's going to turn it into SAMI. So then, and then the cycle continues. Then it's going to give up its methyl group. It's going to become S-adenosyl homocysteine, and it's going to become homocysteine. Take a look at this again. So look at this pathway and look at homocysteine and how homocysteine goes up, straight up into methionine. That's the BHMT pathway. And the way to help that pathway is giving betaine or trimethylglycine. Be careful, because you look for betaine, you'll find betaine hydrochloride, and that is betaine bound to hydrochloric acid. And if you have a patient with a stomach ulcer, you probably don't want to do that. You probably don't want to start giving them acid. You may accidentally give them acid and their stomach needed acid with their meal, but that's not what we're trying to do. You're trying to find trimethylglycine or betaine by itself, not mixed with hydrochloric acid. Just be careful. Don't make that mistake. So if you have high homocysteine and you're stuck and you're giving zinc and cobalamin and the methyl B12 and it's still the homocysteine is staying high, you're going to think about, hey, let me give a little B6, and you're going to think about, hey, let me give a little bit of betaine to kind of help move this thing along. Here are the clinically relevant SNPs. Remember, the methionine synthase SNPs, not really sure which one is. It's not really clear. Now, listen, you can go to different websites and different blogs, and they're going to tell you, hey, you have this SNP, it means this, and you take this food, and you don't eat that food. And the reality is we just don't know. And I do not want to put somebody on some restrictive diet for the rest of their life just based on a guess. What we want to do, we're following our biomarkers, and we want to be smart about the way we do things. So anybody that tells you anything, go back to their studies. As a matter of fact, we have our bibliography, and we're citing our research. Look at those papers and see what those papers do when you get some time, just so you understand the concept a little bit more. So if you look at there's two major clinically relevant SNPs of MTRR. Remember what MTRR does. It's going to help convert B12 to methyl B12, and that methyl B12 then goes and rejuvenates methionine synthase, and the methionine synthase grabs the methylfolate, and it takes the homocysteine that's bound to zinc, and it converts it to methionine. I'm repeating this because I know if this is the first time you're hearing it, repetition is really the key here. And if it is not the first time, and if you already know this, what I want you to do is I want you to just pretend that I'm singing to you and you just enjoy my voice. So what is SAMI? So all of that was to make SAMI. So what is SAMI? SAMI is made from homocysteine, as we saw. It's a major methyl donor, as we talked about. So it helps activate all kinds of enzymes out there and make all kinds of things. And it needs methylfolate, as we discussed, for its production, and it's also available as a dietary supplement. So sometimes we supplement people with SAMI as we're trying to get the SAMI levels up through the back door. So we're going to try to work through different pathways to change homocysteine to SAMI, and then sometimes we're going to want to add SAMI. Now, I want to give you a little bit of a pearl on this, or a little bit of a fun fact. Some people think SAMI is methylated and it's a major methyl donor. So if your homocysteine is high, we are going to give you SAMI and it's going to lower your homocysteine. That is not the case. If you give SAMI, it actually may increase your homocysteine just a little bit. And that's okay if you're trying to increase your stores and methylate, because if you're increasing SAMI in the body, you're increasing SAMI that can get used up and become homocysteine. So yes, you can give SAMI, but watch your homocysteine and make sure that you're changing that homocysteine. You're either going up in the pathway or down in the pathway, and it's not staying as homocysteine. I hope that makes sense. So for methionine synthase, here are some considerations. Optimize homocysteine levels. As mentioned before, for the MTHFR, monitor the MCV. If you see on a CBC that MCV is high, and if you start seeing that it's getting smaller, wonderful. That means that you're doing something right. Avoid alcohol and be careful, because certain strains of Candida can create acetaldehyde, which is an alcohol. So acetaldehyde, it just blocks up that methionine synthase in the liver. So work on the gut health and the Candida overgrowth. And these are the patients that I say, guys, you probably do not want to do alcohol ever. As a matter of fact, you really shouldn't drink alcohol. And don't tell me you're drinking it for health purposes, because I'm telling you it's not healthy in your case. Support zinc, because remember, zinc is a carrier. It carries homocysteine to methionine synthase. Support B12, because B12 is needed for methionine synthase, and you can give methyl B12. 5-HTP you can give, because because sometimes you're going to bypass if the MTHFR gene is kind of is overloaded, or if you have a SNP, then a SNP that decreases MTHFR, like the ones we mentioned, then you can bypass it by giving the 5-methylfolate. Definitely go back to everything that can increase 5-methylfolate, all the natural stuff we talked about in the previous slides. And if the high homocysteine is not budging, consider giving betaine for BHMT. So betaine or trimethylglycine for that pathway in the middle. So now that brings us to COMT, catechol O-methyltransferase. What is this? What is COMT? Well, it is a gene that encodes an enzyme, the COMT enzyme, and it is needed to break down catecholamines, your epinephrine and your norepinephrine. It also helps break down estrogen. So if you have a problem with COMT, your estrogen levels will go up. If your COMT is not working well, then your adrenaline will go up and your norepinephrine. And think about what happens if you have a whole bunch of adrenaline in your system and you can't break it down. You get anxiety, right? Palpitations. And high estrogen, what is that? You increase your risk of blood clots with high estrogen dominance. Think about estrogen dominance. All of that, the COMT, if a dysfunctional COMT can push you in that direction. And take a look down here at the arrows. So the norepinephrine uses COMT and epinephrine uses COMT to become VMA. Now take a look at those cofactors there. So the cofactors are SAMI, which we just talked about, how our body makes SAMI. If you have low SAMI, then you can't break down adrenaline as well and norepinephrine as well. And that's why if you can get your methionine synthase working well, then what that does is it increases your SAMI, and your SAMI can work on that enzyme. And if your enzyme is one of the enzymes that don't work as well based on genetics, well, SAMI may at least give it what it needs so it can do its job. But the second thing is magnesium. Go ahead and put in your chat box, what is your favorite form of magnesium? Put it in there. How many takers do I have for magnesium oxide? It's wonderful. It's oxidized. It's so insoluble. It'll cause bloating. They have it all over the hospitals. Hopefully you didn't say mag oxide is your favorite, but what is your favorite? Go ahead and put them in the chat box. Let's take a look. Let's share some notes here. Now, the data is mixed on cardiovascular disease risk. There's so many studies out there that push one way or the other way. Intuitively, if you have a lot of adrenaline floating around, you do have a higher risk of cardiovascular disease unless you can kind of get a handle on it. This is kind of showing you how it is needed to help break down estrogen. So that's where your estrogen levels may rise if you have the COMT. And you're going to want to look at your estrogen pathways. If you have not done the hormone module yet, you absolutely want to sign up now. As a matter of fact, sign up right now. No, wait till the lecture's over and then sign up. So what is the clinically relevant SNP? There's a couple of them that they'll show, but the V158M seems to be the most relevant. The other ones not so sure about. So how do we deal with this? How are we, what does it mean? And this is where you got to be careful, because when they just turn things, when you do the genetic testing, they'll have the result as red or green, meaning good, bad, or good. It doesn't really work that way. So if you're heterozygous for the VAL-VAL, so there's the VAL-VAL mutation, which you're heterozygous for this, it's upregulated. It'll look green on some of these tests that you look at, or these panels. But what it really means is that your COMT is working too fast. Think about it. If your norepinephrine and epinephrine are working too fast, norepinephrine comes from dopamine. Guess what's going to happen? You're going to have trouble concentrating. And that's what the research shows, because as soon as you get it, your body's breaking it down. These people, we're going to want to decrease, and we'll talk about that in a little bit, but we're going to want to decrease the effect of COMT. These patients, so if you have a patient with ADHD asking for a stimulant, take a look at it. Stimulants may feel good to everybody, but the research shows that the subset of people with an upregulated COMT, which is the VAL-VAL, these people, they actually benefit from a stimulant. But if you get the MET, the ones that don't work as well, if you give them a stimulant, they don't get improvement on cognitive testing. So you can also have the VAL-MET, and that's heterozygous. So VAL-VAL is considered normal. So it's two what they call normal genes. VAL-MET, one normal and one so-called abnormal, that's actually normal. That it evens it out. There's no increased risk. That's kind of what you want. Well, you want anyone, because you want to say, thank you, higher power, thank you, God, for what you've given me. But you know what I mean. You know what I mean. All right. So then if you have the MET means both of them are decreased in function. So if both are decreased in function, now the gene doesn't work as well. And if the gene doesn't work as well, what happens? Your adrenaline can increase, your norepinephrine can increase. So that's anxiety, right? You do better on cognitive exams. If you can focus and you're not stressed the heck out, you can focus. You can use that norepinephrine for cognitive exams. But also then your estrogen levels can go up too, because your body can't break down the estrogen. So those are the three variances. And the data is mixed about cardiovascular disease, but there's some interesting associations, particularly in women. So I would recommend that if you have this enzyme, look at their symptoms and look and see what neurotransmitter symptoms they're displaying, and work on it based on the tools that we're discussing here. But this was interesting. You guys know, like aspirin, you were supposed to take aspirin for primary prevention, and you're not supposed to take it for primary prevention. And this COMT may be the reason why some people may do well and some not so well on aspirin. What was interesting is that patients that had, women in particular, that had VAL-VAL, which means their COMT is working way faster than normal, had an 85% increased risk of cardiovascular disease if they took aspirin. MET, the ones where it wasn't working, had a 40% decrease of risk of cardiovascular disease with aspirin. VAL-VAL upregulated when it came to vitamin E, they had an increased risk of cardiovascular disease if they took vitamin E. MET, and that's where it's working too fast. MET, they had a decreased risk of cardiovascular disease. So if their enzyme wasn't working well, they had a decreased risk of cardiovascular disease if they took vitamin E. So what it looks like is women that have the COMT variant that does not break down the adrenaline as well and estrogen as well, they actually would have a better outcome if they went on vitamin E and if they went on aspirin. Now, these studies are still not standard of care, but when we're doing personalized, individualized medicine, you look at your patient's risk factor and see if they have other indications. Now, we're functional medicine, so what type of vitamin E do you want to give your patients? This is a good one to know. The normal vitamin E that you get at the grocery store or the drugstore, guess what? It is D-alpha tocopherol. So put in your chat box which type of vitamin E you want to give your patient. 3, 2, 1. And what you want to do is mix tocopherols and tocotrienols. That's the active form. There's 8. So there's alpha, beta, delta, gamma tocopherol, alpha, beta, delta, gamma tocotrienol. All 8, you want to do a mixed form, because if you give just one, it can block the others from going into this cell, and it actually may have negative outcomes. But your patients that have MET, where their COMT isn't working, these are the ones that I think about adding that vitamin E. And I wouldn't take this as, if you have val-val, we're never going to give you natural E or a mixed natural E, but it's just something to kind of keep in mind of. This is information most people don't know. This is interesting. It's a smaller study, looked at 773 men, and what they found is that heavy coffee consumption increased the incidence of acute coronary events in men with low but not high COMT activity. So if you had those men with the MET COMT, and coffee, remember, MET, you can't break down adrenaline. Kind of makes sense, because caffeine will stimulate the body to release norepinephrine and epinephrine, or noradrenaline and adrenaline. So you start giving coffee and your adrenaline starts to go up, but you can't break it down. It kind of makes sense that it kind of overworks the heart. Limitations, it was a small study. They only had 78 coronary heart disease events. Here are some considerations with this. We talked about this enzyme and its implications. Here are some considerations. So it may look normal. It may look normal on genetic genie or whatever you're putting it through, but it really could be upregulated, because the 2 fast-acting genes versus one fast and one slow, which is normal. So don't let green fool you. You just got to read it. Be careful, because there's different COMT SNPs. Look for this V158M. That's the one that you're looking at. If the COMT is upregulated and it's going too fast, this is what you may try. You may try quercetin, because quercetin can actually help you block the COMT enzyme, and EGCG from green tea can block the enzyme. Interestingly, if you look at some of the previous COVID viruses, EGCG can actually stop an enzyme called TMPSRR2. And what that does, that enzyme is what takes the spike protein of COVID and it transforms it so that it can bind to our ACE2 receptors. So that being said, it may make sense to be on a little bit of green tea, unless you have an issue with your COMT and it's not working as well. You might want to go for another natural supplement. Quercetin also can block that enzyme. So if it's upregulated, sorry for the tangent, but if it's upregulated, you can give EGCG to block it. You can give quercetin to block it. You could even consider giving a little bit of caffeine, because they're just burning that adrenaline. As soon as they get the adrenaline and noradrenaline, they're burning it to block that enzyme a little bit. You could also consider giving them, because if they're having issues with focus and concentration, then you can consider giving them tyrosine as well, because tyrosine then becomes dopamine, and dopamine becomes norepinephrine. And if you're doing that, and then you're pushing the production, and then you're decreasing, and then you're trying to block that COMT enzyme. I hope that makes sense. If you're heterozygous, so the val-MET variants, really no changes, just say, good job, move on. What about if they have MET? This is the one that's going to look red on the blood work. It looks abnormal. What you're gonna want to work on is these patients, they get adrenaline and they don't break down the adrenaline as fast, and they don't break down estrogen as fast. So work on stress management, because we don't want to stimulate adrenaline release. Avoid caffeine and other stimulants. We have these patients with all kinds of anxiety, and they're like, do you drink coffee? And they're like, yeah, I just drink 2 in the morning. Well, that's great. 2 in the morning, a normal person that breaks down caffeine normal and doesn't have COMT and whatnot, that normal person is going to have 1 cup of coffee by nighttime. We're pushing and stimulating adrenaline here. You might not break down the coffee as fast, or the caffeine as fast. And on top of that, you're stimulating adrenaline. So anybody that has anxiety, you want to try weaning them off caffeine first. If you're getting anxious about me talking about weaning you off coffee, you probably need to wean off coffee. All right. Consider SAMI supplementation, because look at that. SAMI is a cofactor. So give them SAMI so that the body can use, the COMT can use the SAMI to break down norepinephrine and epinephrine. Consider magnesium optimization. Give them magnesium so that enzyme works better. Support the methionine synthase enzyme a couple slides back. Consider giving them creatine. Why? Because the body uses a lot of SAMI to make creatine. So if you give them creatine, what happens is they don't need to use up SAMI to make creatine. Just watch their kidney function. The research shows that it should be safe for the kidney, but just watch their kidney function anyway, because it may elevate the creatinine. Optimize estrogen levels, maybe DIM and sulforaphane, because COMT is needed to break down estrogen. And in women, you may consider using aspirin and mix tocopherols and tocotrienols when appropriate. Pop quiz. You have a 36-year-old white female who presents with depression and anxiety and hyperlipidemia. Her homocysteine level is 15. Go ahead and put in your chat box, what is a normal homocysteine level? Her MTHFR is homozygous for C677T. So homozygous, go ahead and put in the chat box, what percent is that enzyme working at? What efficiency is it working at? So you explain to her how she has this MTHFR mutation. You show her the pathway. You look all impressive and smart. She's like, where have you been my whole life? You're like, look at this pathway, MTHFR. So that you have this gene mutation. So now you can't make methylfolate. And if you can't make methylfolate, you can't make serotonin. And this low serotonin will cause depression and anxiety. So you start her on some homocysteine support. You give her a supplement that has a high amount of methylfolate. You got some P5P in there. Go ahead and put in your chat box what P5P is. You got some riboflavin 5-phosphate, and you have some methylcobalamin. Now, real quickly, for the chat box people, optimal homocysteine is about 5 to 7. Awesome. Her MTHFR, homozygous, that means two downregulated or two slower genes, which means it's less. She's working at less than 50% of normal. So it's about 50% of normal. And then the P5P is pyridoxine 5-phosphate, which is the active form of B6. So you're giving her methylated and active vitamins. And she calls your office 2 hours later. She was so excited because she went and she grabbed the supplement right away, took it and guzzled it down, thinking, where has this provider been my whole life? I am so excited. That why could they never figure this out before? And she calls you freaking out. My heart is racing. I've had the worst panic attack that I've ever had in my life. What are you doing to me? And you're like, oh, shoot. What is your diagnosis? Go ahead and put it in. Put it in the chat box. You know that chat box. What do you think is happening to her? So what does she have? She has an MTHFR dysfunction or gene mutation. So her MTHFR is not working, but she also has the COMT MET variant, which means she also has a COMT gene mutation. So let's take a look at this. What happened to her? Well, this is a patient that had the MTHFR gene mutation, so she had less methylfolate. She's given methylfolate, which allowed her to change her BH2 to BH4. Now her body takes that BH4 and is able to increase the conversion of the L-phenylalanine and tyrosine to norepinephrine, and norepinephrine becomes epinephrine. So now you are giving this patient this methylfolate before it was blocked and she could not make adrenaline as fast. Now you're giving her the methylfolate. And by giving her the methylfolate, she's increasing her adrenaline. But what happens, you increase the adrenaline, but she also has the COMT gene mutation, so she can't break the adrenaline down as fast. So you're driving her to increase her adrenaline levels, and it's happening too fast. This is a case of her being over-methylated. So how do we deal with these patients with an MTHFR gene mutation and a COMT mutation or a backup of COMT? Well, hold that methyl supplement that you gave her. Say, okay, hold off just a little bit. Some people will say, go ahead and get some niacin and take niacin. Why? Because niacin, to break down niacin, your body uses up SAMI. So if it's real bad, you can have them take some niacin right away. Consider giving them magnesium. Why? Because you want to get that enzyme working well. A lot of people are magnesium deficient, so put them on your favorite magnesium. I like magnesium glycinate, magnesium threonate. If they're low in energy, I like magnesium malate because there's magnesium and malic acid. Both are needed for the Krebs cycle. But get her RBC magnesium levels up to about 5.5 at least with the standard laboratories. Consider giving her SAMI supplementation. Why? Because SAMI is a cofactor in COMT. So you give the SAMI and it could potentially block the or it can potentially make the COMT work better because you know you're going to start giving the methyl supplements and they're going to start making neurotransmitters better. And now you want to get her to be able to break down that adrenaline and decrease the drive to make adrenaline. Consider giving her creatine. Why? Put in the chat box, why do you think it's a good idea to consider giving her creatine? The reason is that creatine, you need SAMe to make creatine, a lot of SAMe to make creatine. So if you give creatine, you are going to, one, give her a little more energy and it can help with mood, but you're going to make more SAMe available so that she can use SAMe on this COMT enzyme. Slowly introduce the methylfolate later at lower doses. So slowly start giving her methyl, maybe a tiny, tiny amount, and then consider giving her the other B vitamins in a non-methylated form. So she's not over-methylated. So consider hydrocobalamin. Consider giving her glutathione and or NAC. Why? Because any of these enzymes that we talked about, if you're in an oxidized state, what happens is you oxidize these enzymes and they don't work well. So let's make sure we have enough glutathione floating around so the enzymes do work well. It's a vicious cycle. Methylation is needed to make ATP. Methylation requires ATP. So for everything we mentioned above, consider mitochondrial supplementation, antioxidant optimization, and detoxification. I know what you're thinking. If only I had more cases that I could go over. Guess what? You're in luck. Let's go ahead and do some cases and review what we just went over. Case number 1, you have a 36-year-old white male who sees you for hyperlipidemia. LDL is 265. You put him on an IFM cardiometabolic food plan and start an exercise program. 3 months later, the LDL is 235. You start red yeast rice, 2,400 milligrams daily in divided doses. 3 months later, the LDL is 196. What is your next step? Put it in the chat box. What would you like to do next? Optimize vitamin D, add coenzyme Q10, and atorvastatin or rosuvastatin. And in my case, I'd like to do rosuvastatin. And in my case, I might not jump and do 20 milligrams right away. I might start 5 and check them in a month. It all depends on how fast we need to get it down. But you know what? The guy's been running around with 200 something for a while. You probably could start a little bit less. But why are we going to do vitamin D? Why are we going to do CoQ10? Because we want to decrease the chance of having a reaction to that statin. And you are going to want to screen all first-degree relatives because this patient has familial hypercholesterolemia. Case number 2. An 18-year-old white female sees you for a routine physical exam within normal limits except for fatty deposits around the eye. What is that called? Put it in the chat box. What is your diagnosis and what is your next step? Put that in the chat box. What do you think that this patient has? What is the next step? Xanthelasma is what is around the eye. That's that fat deposit, and you want to order a lipid panel. Part 2, LDL is 480. What do you suspect? Familial hypercholesterolemia. What type of familial hypercholesterolemia? Homozygous. This is 400 something. That's just ridiculous. That's not from eating a little bit too much fatty or high carb foods. That's a genetic thing. And most commonly, It's going to be a mutation of the LDLR or LDL receptor. That's 93% of cases. Homozygous. What is your next step? Start vitamin D and CoQ10. Why? Well, you're going to want to optimize vitamin D and CoQ10 because low vitamin D levels can end up increasing your risk of having myalgias with statins, and CoQ10 is depleted by the statins, so might as well load up on the CoQ10. You want to increase the chance of the statin working, and then you're going to put them on the high-intensity statin. Rosuvastatin seems to be the better one. You want to screen all first-degree relatives. I take it back. It seems to be the better one as long as they don't have severe kidney disease, because you don't have to worry about interactions and whatnot. You're going to want to screen all first-degree relatives because it's familial. And I would refer to a lipidologist. I mean, this is get an extra set of eyes, cover yourself from a liability point of view. This is a challenging case. And since it's 1 in every 300,000 to 1 every 400,000, might want to play the lottery if it's something that you do regularly, because man, those odds are nuts. Case number 3, 39-year-old Black female is seeing you for the first time. She brings in her labs and her LDL is 146. You order advanced lipid testing and note that her homocysteine is 12. Put in the chat box, what do you think about that homocysteine of 12? Are you happy with this homocysteine of 12? What do you think about her LDL of 146? Is that all right? Maybe, maybe not. You order an MTHFR gene analysis and you look at C677T and A1298C, and it shows C677T homozygous, A1298C normal. What is that? Well, she has homozygous, so it's working 50% or less. The MTHFR is working 50% or less, which means that's why her homocysteine is high. So what is your next step? Optimize homocysteine levels, methylfolate and other methyl factors. Make sure you look at your cheat sheet further on in this section in order to mention the things that you do for MTHFR gene mutation. Case number 4 is 67-year-old white female presents to your office freaked out. She recently had a 23andMe genetic test ran as a gift from her son. She ran it through an online interpretation program. She hands you a report showing her MTHFR A1298C is red. She has been reading about MTHFR gene mutation and is now really concerned. History only significant for mild hyperlipidemia, which is well controlled on an IFM cardiometabolic food plan and green tea extract. She has been going to you, a functional medicine provider, for a few years now. So of course she feels fantastic. Apart from the stress of her new result, she's doing great. You check her homocysteine level and it's 7. What is your next step? What do you want to do for this poor woman who we found out has the MTHFR gene mutation, A1298C? Oh my gosh, what do we do? And nothing, because she's fine. Case number 5, a 63-year-old Hispanic female presents with increasing fatigue and bloating. Patient is on a pharmacy-grade multivitamin and multimineral. Symptoms started 6 months ago after needing 4 courses of antibiotics for a URI that would not go away. So when you start thinking 4 courses of antibiotics, it makes you start thinking dysbiosis, fatigue and bloating. It makes you think small intestinal bacterial overgrowth. Did you see our GI module yet? She exercises 5 days per week and is in a great relationship with her husband of 32 years. So she's exercising. Sounds like that relationship is good. She's on a Mediterranean food plan. She takes time to meditate every day. She drinks red wine 5 days per week, no more than 1 serving. You order blood work and an advanced stool panel. The blood work is unremarkable except for a MCV of 103. So MCV red blood cells are elevated on her CBC and an elevated homocysteine of 18. Her B12 and RBC folate are within normal limits. Her stool test was significant for decrease in lactobacilli and bifidobacterium species. Also of note was a 3+ growth of candida. What is causing the elevated MCV and homocysteine, and what would you do for this patient? Go ahead and put that in the chat box. What would you do with this patient? Sounds like she has SIBO. Sounds like she's drinking some alcohol. B12 and folate are normal. Dysbiosis, candida growth. The diagnosis of methionine synthase dysfunction. So what happens, the alcohol in some candida species can block methionine synthase and make her MCV go up. And also if methionine synthase isn't working, then what's going to happen is you're going to end up with an elevation of homocysteine. So stop the red wine and decrease the sugar in her diet. Start a probiotic, something with lactobacilli or bifidobacterium, Saccharomyces boulardii. Consider, because that can help with yeast. If she starts getting like reactions to the lactobacilli or bifidobacterium, you probably would see it more with bifidobacterium. You would consider stopping it and maybe just doing the Sac boulardii, because it could worsen SIBO sometimes. Support her zinc, her B12, and her folate. And that is it. We've went over familial hypercholesterolemia. We went over the different types and the most prominent types and how to diagnose it. We went over the MTHFR gene mutations and how to diagnose and manage them, methionine synthase and what to look for, and COMT. And we even did the bonus, what if you have MTHFR plus COMT, what do you do? We got some bonus slides at the end of these slides, so make sure you take a look at it and you use it for your references. I just want to put things in perspective here. Quick question, how many genes are in the human genome? Around 20,000. And how many genes are in the genome of an earthworm? 20,000, which means we're about as complicated genetically as an earthworm. I don't know what to think about that. How many genes are in a grain of rice? 40,000. So that rice that you eat, because you're gluten-free, is a little bit more complicated genetically than we are. How many genes are in the microbiome? About 1 million. So our genes are not only the genes in our cells. Our microbiome is contributing to the gene pool. Our good bacteria are working with us, producing things and doing whatever those genes do with things. So there have been cases of people that had a drug sensitivity after a course of antibiotics. They take the medication, no problems. They have a course of antibiotics, all of a sudden, they can't take that drug anymore. So how do we support our genes and the genes of our microbiome? The thought is that for every one of these genes that we have abnormal, it is possible that there is a bacteria that can grow in our gut that can do what that enzyme was supposed to do. So how do we support our genes and the genes of the microbiome? By what we eat, our exercise, our sleep and relaxation, our stress management. Genetic testing can give us clues to fine-tuning a treatment plan, but avoid dogmatism. Do not fall into, you have this, so you have to have this diet and that's it. You have this, so you have to take this supplement. Always go back to the basics. Thank you very much for listening. Hopefully you enjoy our upcoming talk by Dr. Saxena, where she will talk to us more about some exercise.